for joining us. Our speaker today is Dr. Gabrielle Merchant. She is an audiologist and hearing scientist and the director of the Translational Auditory Physiology at Boys Town National Research Hospital. She earned her BA from Smith College, her PhD from the Harvard MIT Speech and Hearing Bioscience and Technology program, and her AuD from the University of Massachusetts Amherst. Her translation research focuses on auditory mechanics, auditory perception, and advancing evidence-based practice through improved clinical diagnostic tools. Her laboratory has a particular focus on pediatrics, conductive hearing loss, and wideband acoustic emittance. Please welcome Gabrielle Merchant.
All right, can you guys hear me okay? Thank you for that nice introduction, Heather. I'm gonna share my slides. Can you see those okay?
Yes.
Awesome. Okay, so I'm really excited to be able to share some of our work in my lab on improving the diagnosis of conductive hearing loss in children with otitis media with this audience today with the CTR seminar series. So as Heather said, I direct the Translational Auditory Physiology and Perception Lab at Boys Town, which is kind of a mouthful, so we call it the TAP lab. And as she mentioned, our lab kind of is really interested in how sound transmission happens, kind of mechanical sound transmission through the auditory system. I'll talk about that more in a minute, in both normal ears, but also in ears with different pathologies or disorders. And then how in turn, when things go wrong and there are disorders, how that impacts how people perceive sound. And then finally, kind of taking that knowledge to advance evidence-based practice, particularly through improving our diagnostics. And so some of the topics that we're going to talk about today kind of spread across these different interests as it relates to ear infections or otitis media. And for those of you who haven't had a chance to visit us over here at Boys Town, our lab is on the downtown hospital campus on North 30th Street. And so this is what you see when you come into the lab. And we see a lot of pediatric participants. So it's definitely got a pediatric flair to it. A lot of our participants draw art for us or color art for us that we like to hang up. So it's pretty welcoming and bright. And we have a test suite, an audiologic test suite. So we do some testing in this booth. And this is the side where usually the audiologist who's doing the testing will sit. And actually, if both of these pictures were updated, they'd be very full of equipment and things. We've grown a lot since these last two pictures were taken. So assuming that at least some of you are not hearing and audiology people, I wanted to give you the world's fastest crash course in hearing science and audiology to kind of set us all on a level playing field to some degree. So here's your 4-slide crash course. So we have our ear here. So we really usually break up the ear into 3 parts. So you have your outer ear here, which is your pinna, or kind of the external part of your ear, and your ear canal down to where your eardrum or tympanic membrane is. Then you have your middle ear, which is this air-filled space that has the 3 smallest bones in your body in it, the malleus, the incus, and the stapes. And then that stapes is connected to this kind of snail-like structure here, which is your inner ear, which is comprised of the cochlea, which is kind of the hearing organ, as well as the vestibule and the semicircular canals, which is the balance part of our periphery. And so this is what it looks like. And then how we hear is sounds come down that ear canal. They vibrate that eardrum or tympanic membrane, which in turn vibrates those 3 smallest bones in your body. The first one vibrates the second one, vibrates the third one, and then the stapes pushes in on that cochlea, that inner ear. And that whole system is filled with incompressible fluid. And so as you push on the stapes, you get this little pressure release valve here at the oval window, and that kind of results in a fluid wave that stimulates the sensory structures of the system in the cochlea called the hair cells. And so that middle ear space should be filled with air. And we're going to talk a lot today about what happens when it's not completely filled with air and it's often filled with fluid. So we think about kind of on the broadest sense of hearing loss, breaking hearing loss up into 3, and it's really 2 different types of hearing loss. So hearing loss can be conductive, in which the sound that's trying to get to that inner ear, those sensory structures in the inner ear, those hair cells, is disrupted in some way. So it can't get to those sensory cells. So anything that disrupts the conduction of sound there really gets lumped as conductive hearing loss. So something in the ear canal, something in the middle ear, break in the middle ear bones, things like that, all are going to kind of affect how sound is conducted to those sensory cells. And if something's actually wrong with those sensory cells or the delicate system in that cochlea, that inner ear, or beyond that, like the auditory nerve, those are considered sensory neural hearing losses. And then a mixed hearing loss would just be some combination of those two things, which can be due to one pathology or oftentimes multiple pathologies. And so our lab thinks a lot about conductive hearing loss because these are often the mechanical pathologies that affect those auditory mechanics. And so we assess hearing loss in the clinic using a number of different techniques. So many of you are probably familiar with pure tone audiometry. That's the raise your hand when you hear the beep test. So it's a behavioral assessment of hearing. Adults do this, raising their hand when they hear the beep or pressing a button. In kids, we have to get a little more creative. We turn it into games or kind of a conditioned response, or we look for head turns in response to sound, things like that. But we also have a number of objective or kind of physiologic measures that can tell us about how different parts of the auditory system are working. So this is not an exhaustive list by any means, but this graph in the middle is called tympanometry. It's a measure of how the middle ear is working, and we're looking when we kind of play a sound and apply some pressure, does the eardrum move in and out like we would expect it to? And on the right here, you see otoacoustic emissions. And so this is a sound, we play a sound in and we evoke an emission that should be coming from the inner ear. If the inner ear is working right, then we see these nice emissions come back out and we can record them in the ear canal. But it does have to also go through the middle ear, both the sound we send in and the sound that gets emitted out, the emission that gets emitted out. So we can learn some things about the middle ear too by looking at these otoacoustic emissions. So these are some of the tests I'll talk about today, and I'll go into a little more detail as we talk about those results. So there's your crash course, 9 years of graduate training condensed into 4 slides. So now we will get to the meat of the data I wanted to share today on improving the diagnosis of conductive hearing loss in children with otitis media. And this work really was inspired by an experience I had in clinic when I was training to be an audiologist. And so I was working on a pediatric ENT clinic one day, and we saw 3 kiddos come in back to back who presented very similarly in some ways, but very different in some ways. And so the first child came in and we just look in their ear with an otoscope that you guys might be familiar with. And as an audiologist, I'm really looking for any major gross abnormalities. Is there drainage? Is there lots of wax? Am I going to do any damage by putting an earphone in there? And this child looked grossly normal to me. We did that measure of eardrum mobility. I talked about that tympanometry. And unlike that peak you saw earlier, we didn't see a peak. We saw a flat response. So that eardrum wasn't moving in and out like we normally would expect it to, which is consistent, especially in a young child with fluid in their ear. Or an ear infection. And then we tested this child's hearing. And what you'll notice on this graph is that the marks are kind of farther down. And that means there's some hearing loss present. And we test in 2 different types of ways, through an earphone and through a bone conduction transducer. And basically what this is telling us is there's something likely going on in the conductive part of the system that's causing some hearing loss in this child, which again, is probably consistent with there being some fluid in that middle ear space, consistent with some otitis media. Second child came in and they were a little bit younger. And so similar presentation, grossly normal otoscopy, an eardrum that's not moving quite right, but they are hearing better than that first child. So the marks you see are higher up. We didn't get as much hearing information on them, which is not uncommon. So we're talking about young kids in an age range that's pretty hard to test behaviorally, even with kind of all our tricks in the clinic. And so this gave me some pause. Why does this child seem to be hearing a lot better, even though largely the presentation looks the same than the first child? And then the third child came in, was about 20 months old, same presentation, grossly abnormal otoscopy, flat tympanogram. And this was a child that we couldn't get to condition to behavioral testing. So we couldn't get any of that audiometric information. They just really were at an age where none of our tools of the trade were working, which is not uncommon in this age range. So then the question is, does this child have hearing loss? Do they not? Are they similar to patient A or patient B or something totally different? And so that really has led to lots of questions and continues to lead to lots of questions, but that we are kind of working towards broadly in the lab to understand. So I go to literature. What do we know about ear infections and hearing loss? So we know that otitis media, which is the kind of the fancy term for ear infection, is the most common cause of conductive hearing loss, that kind of hearing loss that impacts sound transduction to those sensory cells in children. It's also the #1 cause for children to go to the pediatrician to get antibiotics and to get surgery. That's usually tube placement. 80% of all children are going to experience an ear infection at some point in their lifetime. But those ear infections or otitis media is highly variable, and it causes variable amounts of hearing loss, from no hearing loss to moderate hearing losses. And one kind of form of otitis media is not that kind of infected state that we think about when we think about a child with an ear infection and a fever. It's really just fluid that persists in that middle ear space. And this fluid can persist for days to weeks to months. And really the only symptom in that case is the hearing loss. And there are great clinical practice guidelines that kind of help us think about how to manage these ear infections based on kind of the diagnostics that we have right now. And they do, as part of that, recommend hearing evaluation of these children and to use that information to guide management decisions and how to manage them and whether to watch and wait or think about tube placement. But again, as you saw, not all children are able to undergo a behavioral hearing assessment in this age range. So thinking back to kind of what we know and that clinical dilemma, we still have the question of, well, why does that first child have a lot of hearing loss? Why does the second child not? And does the third child have hearing loss? And do we have any tools to be able to figure that out, given that they weren't able to condition to behavioral testing? Also thinking about all this variability, what are the factors that are causing this variability in hearing loss? Is it how much fluid there is? Is it how thick the fluid is? Because it can vary from really, really thick kind of glue ear, some people talk about, to more thin water-like effusions. Is it whether infection is there or not, purulence? Some of these infections or fluids seem to persist for just a few days to a week, and then they clear on their own. Some of them can persist for months at a time. So what causes a certain episode in a given child of OM and in turn its hearing loss to persist? Over that time period while it's persisting, is it stable? Is it fluctuating? What are the factors that are influencing that? Are there any factors that predict whether you're going to have an ear infection in one ear or both ears? We see a lot of asymmetries in this population. So just because you have something going on in one ear doesn't mean you have the same thing going on in the other ear. And then kind of a longer term goal and question for us is, does this cumulative hearing loss over time, especially in kids who have really chronic ear infections that are causing hearing loss, cause a certain amount of auditory deprivation, a lack of auditory input during critical developmental periods, because again, these are young kids, that can lead to deficits in speech and language development and things like binaural hearing, which is how our two ears work together to understand speech and noise or figure out where sounds are coming from. And how do we identify what kids might be at risk for those deficits? And finally, how do we use all this information to think about, how do I treat patient A? How do I treat patient B? How do I treat patient C? Should we watch and wait? Should we prescribe antibiotics? Should we place tubes? And what measurements will inform us how to make those decisions best? So those are lots and lots of questions to give you a flavor of the many different things we're kind of interested broadly in this work. So for the data I'm going to share today, most of these children have been recruited from our otolaryngology or ENT clinics, and these were children with that kind of OME state, so that otitis media diffusion, so not kind of that active infectious state where they're likely to get antibiotics, but these are the kids that have had fluid in their ears that's been persistent, and these are children who are scheduled to undergo tube placement. They range in age from 8 months to 11 years old, but they really skew to that younger end. So the average age was about 34 months for most of the data you're going to see. We do have an age-matched population of children who don't have any recent history of ear infections or any chronic history of ear infections. And then we also are really isolating these studies to children with just that conductive hearing loss. So you can certainly have a permanent sensorineural hearing loss, things wrong in the cochlea, and also then get an ear infection as a child. For the sake of these studies, we've ruled out any kind of problems in the cochlea in all of these participants. So the problems we're looking at are just isolated to that middle ear. So our study protocol involves identifying these children in the ENT clinic. We have an ENT who works in our lab and does a lot of recruitment in his clinic for us. And were scheduled for tube placement. That's what kind of made them eligible to enroll in the study. They were offered to enroll in the study. They enrolled. And we then bring them in some period of time later prior to surgery. And we try to bring them in 24 hours prior to surgery, but usually it's in that 24 to 48 hour window before surgery. We want to see them in the lab as close in time to surgery as possible. And they come in and do a 1 to 2 hour battery of tests in our lab. And so this includes that behavioral audiometry, that eardrum measurement of tympanometry, those otoacoustic emissions we talked about, which are called DPOAEs. And then we do an advanced form of tympanometry called wideband tympanometry or wideband acoustic emittance that I'll talk about a little bit later. That's largely been in the research literature that's kind of slowly making its way into clinic, that we think can provide some additional information about what's going on in these kids. Then on the day of surgery, we see them in pre-op to confirm there hasn't been any change from the day we saw them in testing. And the variables related to their OM that we can characterize in the OR are characterized. So this includes our ENT looking really carefully at the ear and deciding how much fluid is in the ear. Is it completely full, or is there some evidence of air? What's the viscosity? Is it mucoid? Is it more serous and thin? And we actually collect a sample of the effusion and try to really quantify these variables. Though I'll say that that's been more complicated than we initially thought it would be. And it actually, I think these subjective qualifications are more reliable. And then we bring them back a month post-op to complete the same battery of tests and make sure everything kind of pops back up to normal now that they've had tubes placed. And I get a lot of questions about that effusion collection. And so this is just, these are just some pictures that kind of show how we do that. And so we use a Jun-Timp tap, which attaches to the suction in the OR. And you can place this part of it kind of close to the myringotomy, the hole, and it sucks some of that effusion and drops it into this little sterile cavity that I can then take into a wet lab, suction up that effusion. So here's some effusion from an ear. And then we were using this RioSense microviscometer, which is has a microfluidic chamber in it that measures the viscosity and can also quantify kind of the volume on a very precise scale. What we found is that these effusions are not homogeneous. And so honestly, if you ever like blow your nose when you have a cold, like you can see that there's like areas of that mucus that are very thick and areas that are very thin. And so what this viscometer is trying to do is to push that substance through a little microfluidic chamber and figure out what the viscosity is. And the viscosity is changing. And so even if we spin these, there's still like these kind of chunky parts and these thin parts. And so it doesn't know what to say the viscosity is because it's different throughout it. And so that's why those subjective qualifications have been better. And we're also not able to suction the entire effusion out of that middle ear space. So we can't quantify the volume. And what we're finding is, as it relates to the mechanics, everyone's middle ear is a little bit of a different size. And so even if we knew exactly how much fluid there was in that middle ear, unless we knew exactly how big their middle ear was in terms of volume, we wouldn't be able to relate those two things. And so again, the subjective classification of volume has seemed to be more important to the mechanics and kind of what's happening in the system. Okay, so some data. So we're going to start by thinking about what characteristics of these episodes and these effusions are interesting for us to look at and how to group the data. So again, all these children had that diagnosis of OME in clinic. And then there was a period of time, 5 to 57 days before they had surgery. Sometimes it takes a long time to get in for surgery. Sometimes there's kids that get sick and has to get canceled and it gets postponed. Some kids get in really quickly. There's all sorts of variables that affect it. So some of these kids got in really quickly, but some of these kids, it took a couple of months even to get in for surgery. And so at the time of surgery, whether it was 5 or 57 days later, there were 61% of the ears that we saw that still had fluid present, which meant 39% of the ears no longer had fluid present, and therefore we can't characterize anything about the fluid. We call those clear ears. So I wouldn't call it a normal ear. It's had a very recent ear infection, and you'll see how it might look different than normal ears later. And so we kind of distinguish them from normal ears and just call them clear because there's no fluid at this time. Of the 61% of ears that had fluid, we looked at the volume and viscosity of those ears, and we see pretty good variability in the volume of the effusion. So 61% of that 61% had completely full effusions. There was no evidence of air whatsoever, no air bubbles, anything like that in the middle ear space, whereas 39% of ears were partially full. And that can mean like a few air bubbles to 25% full and everything in between. And when we look at viscosity, the vast majority of ears were mucoid, that thicker effusion. There were only a couple ears that fell into kind of that thinner fluid, what we'd consider serous, and one was infected or purulent. And so because we just had kind of this minimal variability in terms of the viscosity, we really couldn't look at that in a systematic way in terms of how it was affecting these outcomes. And so for the data kind of moving forward, you'll see it's grouped largely based on the volume of the effusion, how much fluid is there. And we ultimately characterize it as either clear, no fluid, partial, a little bit of fluid to kind of some air bubbles, or completely full, no fluid at all. I mean, no air bubbles at all. Okay, so the first audiometric test we're going to talk about is that pure tone audiometry, the audiogram here, the beep, raise your hands. So this is our behavioral response of hearing. And what you'll see is pitch along the x-axis here, and it's usually actually on the top in a lot of plots, from low pitches to mid pitches to high pitches, from left to right. And then the left is intensity of the sound, and the farther down a mark is, the louder we had to make it for someone to hear. So we're measuring kind of thresholds or the softest sounds people can hear. And so when we look at our kids with otitis media with effusion, we see lots of variability in the hearing loss, which was not surprising to us because we've seen that in the literature before. But what's interesting is when we separated these groups by how much fluid was in that middle ear, we found that effusion volume does seem to be really driving how much hearing loss they had. So kids who had completely full ears of effusion, no evidence of air, have these kind of what we consider moderate hearing losses. They're walking around and it feels like they're probably hearing underwater. In contrast to ears that were either partially full or clear or empty at the time of that tube placement, who have what we consider kind of borderline normal hearing. So this 20 dB-ish level here is kind of on that border of normal hearing. And so you can see that both of these groups are kind of hovering. There's actually not statistically significant differences between these two groups. So the ear seems to be really resilient. If it has even a little bit of air in that middle ear cavity, you can still get some reasonable sound transmission. That said, both of these groups are poorer than their age-matched normal control comparison group. And so even though they'd be considered probably clinically normal, whether or not there might still be some influence of the fact that they're still not hearing as well as their peers who don't have ear infections or a history of ear infections recently, might be something to consider. All right, so next we're going to look at standard tympanometry, and this is a really common measurement of how that eardrum is moving, so we can get different type of curves. As you see on the right here, it tells us about the pressure in the middle ear, how well the eardrum is moving, and also something about the ear canal volume. And so this is just an example of the results that we got from these standard tympanometric measurements. But basically, this is a child who had a partial effusion on the right ear and a full effusion on the left ear. And you can see their graphs look basically the same. So we're not seeing good in and out mobility. We don't see that mountain. They both look pretty flat. And there's nothing really notably different about it, whether the ear is partially full or completely full. So even though the volume of the effusion seems to be driving the hearing loss, and therefore might be an interesting thing for us to be able to know about, kind of our standard measure of eardrum mobility can't predict how much fluid there is in the middle ear. We also measure otoacoustic emissions in our lab. Usually if you can get behavioral testing on a patient, you don't do this otoacoustic emission test, but we were curious what it would look like and how it would vary in these children. And in some kids, we aren't able to get the behavioral testing, so it's handy there. And these otoacoustic emissions, again, are kind of a measure of outer hair cell function in that inner ear. And so we play a sound in, and it emits or elicits a response that's emitted from the cochlea back into the ear canal. So it has to go in and out through the middle ear actually twice. The sound going in has to get to the inner ear, and then the emission has to come back out. And again, its primary purpose is to figure out, is the inner ear working right? But again, because it goes in and out of the middle ear, we get some information about the middle ear as well. And so what we see here, these are across frequencies. So from low frequencies or kind of mid frequencies up to high frequencies. The higher up the mark is on this graph, the better the response was. So the larger in magnitude the emission was. And so on the top in the triangles, you see our normal hearing control. So they have kind of what we'd expect in this age range, nice emissions, big emissions, especially in the mid frequency range. And then as the ear kind of gets more abnormal, so the clear ears that have that recent history of infection, probably still some inflammation going on, they have poorer otoacoustic emissions. The partial effusions have even poorer otoacoustic emissions, and the full effusions you really don't see. They're kind of in the noise floor, which you can't totally tell from this graph. But these four groups are largely across the board statistically different from each other. And so as the kind of ear continues to fill with fluid, we see fewer and fewer emissions present. And this is a little bit different than the hearing test results, where the clear ears and the partial ears aren't different from each other. And that's probably because this measurement gets a double whammy through the middle ear, which is where the pathology is. And so we have to play the sound, it has to get into the inner ear. That's how we hear. That's kind of forward transmission that goes up the pathway. But then for us to measure this, that little emission that's coming back out also goes back to the middle ear. And it's probably why those partial effusions look poorer than the clear ears. And then the last measurement that I wanted to talk about is something called wideband acoustic emittance or wideband tympanometry. And this is a measurement that's been used primarily in research for the last 20 or so years, and it's slowly getting translated to clinic. It's now FDA approved with a couple of devices, and it's similar to tympanometry in that it's telling us how the eardrum in some ways is moving and therefore how sound is getting transmitted into the system. But a big difference is that our standard tympanometry measurements are in response to just a low pitch tone generally. And these are measurements that are made in response to wideband stimuli. So low, medium, and high pitches. So we're getting information about the mechanics of the system across this broad range of frequencies, which we don't get from standard tympanometry. And it tells us a lot more about sound transmission that we don't get from standard tympanometry. And so the kind of parameter or outcome that we look at most commonly right now from these measurements is how much energy was absorbed by the ear. So we play this wideband stimulus. Some of it's going to get absorbed by the ear, some of it's get reflected back. And so we're really looking at how much was absorbed, what percentage was absorbed. And so this either goes from 0 to 100 or 0 to 1, 1 being everything was absorbed by the kind of system, 0 being everything was reflected back. And so here's that absorbance. Again, we're looking across a wide range of frequencies, and 1 is everything was absorbed, 0, nothing was absorbed. And this is the range of individual responses for our ears with otitis media. And I think this really highlights nicely how variable this pathology is, because the responses are all over the map. And they can look very, very different from each other, even though technically they have the same thing going on. However, if we separate these tracings by whether they, by their effusion volume, we see really different patterns. And so these are group level data, but you see that those ears that are really full have very low absorbance, and which means that not all that sound that we're emitting is getting in, a lot's being reflected back, which doesn't surprise us because there's fluid in there that's kind of impeding that sound transmission. If there's a little bit of air, it's a partial effusion. We see better absorbance, higher absorbance kind of across the board. Those clear ears are trending a little bit closer to that black curve, which is our normal ears. And then you see the black curve there, which is normal. And you might say, well, shouldn't normal just be kind of one black line at one across, like everything's getting absorbed? But our ears are not perfect. There's kind of some differences in how we transmit low frequency sounds and how efficient the ear is at middle frequencies versus high frequencies. So this is a pretty expected normal curve. And so it's really the difference from normal that we highlight here, and how different, especially that full effusion is. And so this was pretty interesting to us, that even though standard tympanometry doesn't seem to be different between different effusion volumes, these measurements seem to be very different with effusion volume. And clinically, because I don't see groups of patients, we were really curious about, on an individual level, does an individual tracing have that same kind of very strong characteristic? And could we use individual data to predict the volume of the effusion? And so I won't go into all the nitty gritty of this, it's published, but basically we took all the individual data and designed a machine learning algorithm where we trained it on 70% of the data and then validated it on 30% of the unseen data to say, is this single tracing a full, a partial, a clear ear, or a normal control ear? And we get really good accuracy of saying whether there is fluid in the ear or not, so full or partial versus clear and normal. And what's most interesting to me is that we get really good distinction between full and partial ears. So 89% accuracy, which though not 100% is pretty high for a diagnostic test like this, and higher than kind of our current clinical tools. It has a bit of a harder time distinguishing clear ears from normal control ears because they are very similar. So the accuracy drops to 65%. The clinical implications of distinguishing a clear ear from a normal control ear are probably not as big as saying this child probably has a lot of hearing loss versus borderline normal hearing. But we still wanted to try to improve that further. And so we have been combining these kind of tracings that we get with a computational model. And the big goal of this is really that we're making these measurements in the ear canal, but we want to know what's going on in the middle ear. So a lot of why we are using this computational model is to kind of remove the effects of the ear canal to get a more precise measurement of what's happening in the middle ear. And kind of the summary here is when we do that, we do see some improvements in performance with certain distinctions, particularly for that clear normal distinction. And that's likely because we're pretty close to ceiling on the other distinctions because they were doing so well with the absorbance alone. So unlike standard tympanometry, the measure we use very routinely in clinic, these wideband absorbance measurements do seem to show a lot of promise in being able to predict this effusion volume. So this is that same example of the tympanometry data I showed you, where the right ear had a partial effusion and the left ear had a full effusion. Temps look the same, but this absorbance tracing looks very different between the two ears. And this is just another case, because I always think looking at individual cases is fun, of a child who we saw in 2 different visits, and we were curious about whether there was a change between the visits. And so on their first visit, they had very flat tympanograms, so no real mobility of that eardrum. These are that otoacoustic emissions, largely absent. There was 1 OAE in that right ear. And here's their absorbance tracing. Left ear is blue, right ear is red. And you can see it's pretty low absorbance across the board. So the right ear is a little bit higher, and that might be why 1 little OAE popped out. And then at their second visit, a few weeks later, we still see pretty abnormal tympanometry, but the difference is that their otoacoustic emissions looked really nice, which is an indication for us that this is an ear that's now getting some decent sound transmission, and the wideband response was consistent with that. We see a big improvement in the absorbance. So it's still not normal, but likely hearing normal to near normally and getting good sound transmission or pretty good sound transmission. So we've been pretty excited about these data in large part because, again, if we go back to thinking about those clinical guidelines, having some indication of how a child is hearing when they have these episodes of OME is important for kind of thinking through what's the best management strategy. But behavioral testing of kids in this age range is pretty hard. And so we get limited behavioral data. We can't just test their hearing all the time and get good data, especially on individual ears, which I'll talk about later. And so if we're able to, if we're not able to get that behavioral data, but we can get this measurement of absorbance on them, we might be able to infer, well, if this is the full ear, they're likely not hearing very well. They're likely in this moderate hearing loss category versus if it's partial or clear, where they're likely hearing normal to near normal. And this was actually handy to me not that long ago when I brought my son in to participate in a research study with one of my colleagues, and she was doing some normative testing. So I brought him in as a normative control participant. He does have a history of ear infections and tubes. I thought he was hearing fine at this time, and his tubes were extruded. And so we thought everything was normal. And she did tympanometry as part of her protocol, and it was very not normal. So again, you don't see these nice mountain peaks. They're very flat. And so I had no idea that he had some fluid in his ear at that time. Bad mom audiologist. And so thankfully she has wideband in her lab. And so we ran the wideband. And I was a bit reassured that these were tracings that were consistent with a more partial effusion. So it's likely that even though he had fluid, he was hearing kind of normally to near normally. And maybe that's why I had no idea what was going on. And this isn't an uncommon finding actually in this study. When she was trying to collect all this normative data, we ended up with such a large instance of incidental findings of abnormal middle ears that we ran them on this protocol and kind of wrote a whole separate paper about kind of how this middle ear status, this incidental middle ear finding might affect the measures that she was looking at because it was so common. And here's just one more kind of interesting case. So this was a case pretty early on in this study. And so this was a slightly older child, an 8-year-old who was seen in clinic for suspected ear infection, otitis media. And these are his clinical results: bilaterally flat tympanograms, which means that eardrum's not moving well, hearing loss in both ears, that conductive hearing loss. And so he saw audiology first, and then he goes over to our ENT, and the ENT actually noted on otologic exam, I thought the middle ear was aerated. And so our research audiologist was in the clinic that day and asked, can the tympanograms be wrong? Like, he was pretty convinced this child did not have fluid, but you've got flat tympanograms and conductive hearing loss in an 8-year-old, and that's kind of a classic presentation of OME, and they're taught you hear hooves, you think horses, not zebras. And so we actually sent the child back to audiology to repeat his tympanogram. It was consistent and still flat. And so they decided, well, it must be fluid. We're going to schedule you for 2 placement. And he thankfully enrolled in our study. And so we saw him a few weeks later, right before late at night, actually, before he was going to have surgery. And we ran him through our test battery, and the results were pretty consistent with clinic, flat temps. They don't do otoacoustic emissions again in clinic if they have behavioral data, but we did them, and we saw at least 1 otoacoustic emission in the right ear and pretty good otoacoustic emission in the left ear, which means that this child likely doesn't have a ton of fluid in their ear, and the absorbance was consistent with that as well. So these were not ears that were completely full of fluid. And so there's not fluid in this ear, which is not explaining the amount of hearing loss. So long story short, the pattern of results didn't add up. We were convinced this child did not have fluid either. And so we decided to unblind the ENT in the morning. He's normally blinded to all the lab results, not to bias any of his interpretations in the OR, and talk to him and see, what he wanted to do. And he was like, so happy to see the absorbance tracing because he was like, I knew there wasn't fluid, but I didn't have a test to kind of assure me of that. The test that I had said this child probably has fluid. And so this isn't a normal ear. He obviously has hearing loss. We think he probably has a congenital fixation of some sort, but it wasn't fluid, and that tube placement probably wasn't going to help him. So ultimately they talked to mom. Mom was also convinced it wasn't fluid. She has a chronic history of having multiple tube placements that never resolved her hearing loss, and now has persistent hearing loss that they blame on the tube placement. Fixations can be congenital in a lot of cases, and hereditary. And so it's likely that she might have the same thing going on, and it hasn't really been identified before. And so they unfortunately moved shortly after that. And so I never got the final answer of what's going on, but we did recommend some follow-up, potentially imaging and thinking about hearing aids and things like that, but they canceled the surgery. So a lot of this work rests on the idea that testing hearing in children with otitis media with effusion is hard. And while we kind of know that from our own clinical experience, we did want to quantify it. And so what we did is we looked at, a group of kids that we had seen both in the clinic and in our research lab. And I have to say, I think our clinic at Boys Town have some of the best pediatric audiologists in the country. And so if they're going to get good behavioral data on these kids, they're the people that are going to get it. And so what we found in looking at how successful are we in getting behavioral data on these kids, that behavioral audiogram, we found is that at about 20% of kids in clinic, we don't get anything audiometrically. So we're only getting some audiometric data in 80% of kids. So that's still a decent chunk. However, in 53% of kids, we're only getting information in the sound field, which means we're only getting information when we play it from the speakers. They're not giving us information about their ears individually. So if a child were to have a lot of hearing loss in one ear and normal hearing in the other ear, they would do really well on that sound field test because their normal ear would kind of help them respond at normal levels. And so we could miss hearing loss in one ear. And so we only get ear-specific behavioral data on 27% of kids. And so again, while that sound field data is really useful, it probably tells us that they have access to sound that's adequate for speech and language development. There are things in our auditory development that really rely on our two ears hearing well and kind of how they talk to each other and interact with each other, especially how we listen to noise and how we localize sound. And so sound field data could miss a hearing loss in one ear, and it won't tell us about how these kids, their binaural hearing could be impacted. And so anything ear specific that we could get on these kids could be helpful. It could just be one more little piece of information to think about, both in terms of long-term outcomes and how we should manage these kids. In that same population of children, we're able to get that wideband absorbance measurement that's predictive of their amount of fluid in almost all ears. There's always the occasional child or two that is just so sick of having their ears touched that they will still not let you measure this, but in almost all kids, we're able to get it. And so we're now trying to take this a step further and say, well, can we do better than just infer this is a full effusion, they must not be hearing well? Can we predict how much hearing loss this child really has? And so as a first pass at this, what I did is I averaged basically their hearing at kind of the 4 important speech frequencies, 500, 1,000, 2,000, and 4 in each individual child, and compared it to what admittedly I thought was not going to work at all, kind of just averaging this whole absorbance curve down to one number. We call it the average absorbance, and compared those two values. And what we find is a really, really strong correlation between their average absorbance and how much hearing loss they have, the average ear bone gap. And so as the average absorbance decreases, we see a really systematic increase in how much hearing loss they have. And so we are continuing to take this kind of a step further, apply some of our computational modeling strategies. And our goal is basically to be able to have a model that can take one of these absorbance measurements and predict within a clinically meaningful kind of test-retest number, so within 5 decibels, what this child's average ear bone gap would be, or average conductive hearing loss. And so we've published some preliminary data on that, and kind of that work is ongoing with a recent R01 to really refine that model and those data. And our hope is that eventually we'll be able to develop a tool where an audiologist or a clinician can make this really quick and easy measurement, and it would spit out, we think this child has an ear full of fluid with an estimated conductive hearing loss of 47 dB in this case, versus here's a partial ear where we think they're hearing quite well, an estimated conductive hearing loss of 12 dB. And I think this will kind of alleviate some of the burden on the clinicians to do a lot of the interpretation of these somewhat complex tracings in real time. And so this is some in progress work as well. We're also trying to thinking about that translation to clinic, like how do we get this really to move into clinic, develop some tools for clinical staff to use. So one question that we get a lot is great. I want to use this, but like, what do I write in my report? What do I write to the referring provider that will be meaningful if they aren't as familiar with this? So these are also kind of in progress, and we're working closely with our audiology clinic to refine these as we start to roll them out a bit ourselves. But just some guidance for some phrasing that you can use, some language that you could use potentially in your reporting, some interpretation guides, kind of infographics that we could leave in our booths and things to help people start to think about how to discuss these findings, at least for this specific population. All right, so with my last little bit of time, I wanted to talk about some more recent work that we started about a year ago on monitoring episodes of OME and hearing loss via mobile testing. So a lot of the work up until this point is really focused on, at a single visit, a child comes into clinic, how do we assess them? How do we take that assessment and think about management of them? And I think that is really going to be helpful, and there's useful utility out of that, but that doesn't tell us anything about kind of that cumulative impact over time, how these ear infections and hearing loss might be fluctuating over time. And we actually don't have really solid data about how frequently this fluctuates, how much the hearing loss is fluctuating and things like that, just because it is it would take a lot of very careful longitudinal monitoring for that. So that's what we're trying to do. And so the goal of what we call this mobile OM project is to understand really the trajectory of these episodes, and then figure out, like, in a child that's effusion clears very rapidly versus a child that has very persistent fluid, is there anything that was indicative of that in any of our measures, particularly the wideband measure, that would have helped us predict that? Is there any prognostic value to any of our assessments? So all of these kiddos have this initial battery of tests that we've talked about: otoscopy, tympanometry, that wideband acoustic admittance measurement, the otoacoustic emissions, and the hearing assessment. And then we monitor them weekly with our van. And so we go to their homes and we repeat most of those tests except the hearing test, because it's the most time intensive. The other ones, the child just kind of has to be still and compliant for us. And we monitor their middle ear status. If it looks like there's been a change in some of those monitoring tests, we do try to repeat the hearing test to see what the influence of that is on hearing. And so these are just some pictures of this mobile testing. It's been really fun. This is a van that was originally for a different investigator for a language study. So it's not, wasn't kind of designed with hearing testing in mind, but we still have been able to do a lot with it. So drive to their home, set up our equipment, bring them into the van. The kids really seem to love it. The families actually have enjoyed getting to know about their kind of child's ear infection status over time. They like the added information. And thanks to funding from a recent R01, we are now designing a new van because this other one is a shared resource that we've been probably taking up more than we will be able to in the future as more and more people start to use it. And so this will be a dedicated van for this project, and that we're designing with as much of kind of our testing protocol and the acoustics of kind of doing these tests as we can in mind. So this will be done in a few weeks, and we're really excited to add another van to our fleet. And to give you a flavor of what kind of data we're getting from this, I don't have a lot of the cumulative data analyzed yet, but these are kind of some case studies to give you an idea. And so these are 3 different weeks of our testing. We're seeing these children at least 4 times weekly, 4 weekly visits while they have an ear infection, and then we monitor them monthly after that ear infection resolves. In some cases, if the infection is ongoing for more, the fluid is persistent for more than 4 weeks, we continue to monitor weekly until it clears, and then monthly after that. This was a control participant, so we did that kind of 4 weekly protocol. So you can see this is a tympanogram measurement. So we see the mount in there. So that's pretty normal. Their hearing was pretty normal. We had pretty normal wideband, nice otoacoustic emissions. We go back week 2, profile looks the same. Week 4, profile looks the same. So we see that nice, stable, normal response. Interestingly, it's actually almost harder to find kids that don't have in our control group that don't then have some middle ear dysfunction at some point and therefore aren't true controls than it is to find kids with ear infections. This was a child who was enrolled because they had abnormal middle ear status in one ear. So the right ear, you can see, doesn't have a peak. It's really flat. They have hearing loss in this right ear, and their absorbance in that right ear is really low. The left ear is pretty normal. There's some negative pressure there. no OAEs. We go back a week later and we actually see some improvements in the right ear. So it's hard to tell from the tympanogram, the right ear doesn't have that negative pressure, but you see that right ear has a few otoacoustic emissions present. And if you look at the absorbance, you see it has increased kind of across frequency and their hearing increased. So now we're at like 25 to 20 dB, whereas here we were at 30 down to 45 in one place. So their hearing's gotten better and the wideband seems to be really sensitive to that improvement in a way that the tympanometry is not. And then we went back a week later, and interestingly, it got a little worse. We see that the hearing loss has dropped a bit, and the absorbance has also dropped a bit, and now there's no OAEs present as well. And so one thing to highlight here is there's a big difference between the two ears. So again, we see this a lot, big differences between the two ears, but also how sensitive this wideband measurement seems to be to these maybe smaller changes in middle ear status that are also correlating to changes in hearing. And then this is just one more case study of a child whose ears were pretty similar. At their initial visit, they had what looks like a partial effusion, some OAEs present, kind of abnormal tympanometry, but wideband was consistent with a partial. We go back a couple weeks later, and the profile has improved a bit. So their absorbance, it's hard to tell, is a little bit higher in both ears, even though the tympanograms actually look, if you were trying to interpret them this way, probably the worst of all of them. And you see a little bit of an improvement in the otoacoustic emissions, particularly in the right ear. And then went back at and then by week 5, we saw another big change where actually the absorbance looks the poorest of all the visits, and the otoacoustic emissions are now not present in either ear. And what happened was this child got acute otitis media. So that fluid that's been persistent in their ear got infected. And so it was now completely full effusion with a lot of infection present. Fortunately, this was the week right before they were having tubes placed. So just some takeaways. We believe that this wideband acoustic emits measurement shows pretty strong potential in differentiating how much fluid is in the middle ear, which can't be said of kind of our standard measure of how we measure middle ear function. And this seems to be significant because how much fluid also appears to be driving whether and how much conductive hearing loss is present. And so knowing how much hearing loss is present, especially in an ear-specific way with an easy test, would be a really helpful tool to add to our toolkit in audiology. And then we have that kind of preliminary data that suggests that we might be able to directly predict how much hearing loss a child has from these wideband acoustic emits measurements. And that wideband on the longitudinal studies does seem to be sensitive to these subtle shifts in middle ear status that do correlate with hearing changes. Again, that could help us kind of monitor hearing without having to do a behavioral hearing test every single time to better understand these fluctuations and how the hearing changes over time. And so with that, I just want to thank the members of my lab who make this work possible. I could not do it without them. I kind of want to highlight a few people. So Sarah Elsleem is a research audiologist in the lab, senior research audiologist, who also manages the lab and has been with me since the lab opened. And I could not do this work without her. She's amazing. Rick Tempero is an ENT who spends most of his time in the clinic and the OR, but with whom we couldn't do this work. He's been both a scientific and clinical collaborator since the lab opened. We recruit all of our patients more or less through his clinic or through collaborations with his colleagues, and we're very grateful to his input. And Jane Ken and Leah Gibbs are both research audiologists in the lab who work part-time in clinic and part-time in research, and we love that that keeps us very closely connected to our audiology clinic, and they just bring so much great insight from the clinic into the lab and vice versa, and it's been so wonderful to have them as part of this project, and then various research assistants who are also wonderful and help make sure our patients and families have really great experience in the lab and have a lot of fun, as well as collaborators. So Steve Neely, I've been working with since I was a PhD student, and he's continued to collaborate with me all these years, and I couldn't do any of the modeling work. Certainly without him, the predictions of hearing loss, he's had a really key and important role. And he's also just been a wonderful mentor through the years. Emily Buss collaborates with us when we think about binaural hearing and has just been also a really great mentor since I came to Boys Town. And Jeff Cruckley, who helps us with some of the statistical analyses, lots of recruitment and data collection support, and our funding from NIDCD and NIGMS. And if people have questions, I think we do have some time, and my contact information is on there too if people want to contact me at any point about any of this.
Please feel free to unmute yourself or type a question in the chat if you have one.
See the chat. Well, we'll just chalk it up to that. It was just so clear. There are no questions, but I know it's also everyone's lunch hour and people are probably multitasking. So if anyone does have questions, comments, wants to talk about any of this further, please definitely feel very free to reach out.
Thank you so much for your time today, Dr. Merchant.
Thank you for having me and for the opportunity to share with this group.
Take care. Bye-bye.